cases and more than 600,000 deaths. But according to the National Cancer Institute, there are more than 18 million cancer survivors in the United States. That's more than 5% of the population. And the number of cancer survivors is projected to increase by almost a quarter in less than 10 years. Tonight, we're going to highlight the battle against cancer, where we are and where we need to go. Hope and healing, finding answers to cancer, begins now.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.
Good evening and welcome to Hope and Healing, Finding Answers to Cancer. I'm Olga Villaverde, and joining me virtually is my co-host, Dr. Michael Zinner, CEO and Executive Medical Director at the Miami Cancer Institute. Good evening, Dr. Zinner.
Good evening.
You know, Dr. Zinner, this is a very special topic for you and for me, as we both lost two very special people to cancer. And although there are plenty of positive statistics, I believe we still have a long way to go. Do you agree?
That's right, Olga. Cancer continues to impact so many lives, but we want you, the audience, to know there is hope in the battle against this deadly disease. For example, in the last 30 years, we've seen an increase in lung cancer survival of 24%. 44% for colon, and amazingly 90% for breast cancer. So just in my career, I've seen these dramatic improvements, and I think there'll be more to come. Olga?
And those are good numbers, good improvements. Thank you, Dr. Zinner. We have so much to discuss, and we have a wonderful panel joining us. Let's start with Dr. Kelly Tice from Florida Blue Guidewell. Also joining us, Dr. Carlos Del Rio, the Associate Dean at the Emory University School of Medicine, and Dr. Kavita Patel, a primary care physician based in Washington, D.C. I want to welcome all of you. Thank you so much for your time.
Happy to be with you.
We also want to invite you, our viewers, if you have a question, please send us an email to questions@allhealthtv.com. That's questions@allhealthtv.com. So as we begin, I think it's important that everyone understands exactly what cancer is. So here's some great information from the Miami Cancer Institute. Cancer is a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. And it is essentially a disease of broken genes or mutations. Dr. Zinner, can you explain a little bit more about these broken genes?
Yes, Olga. So some of these broken genes are inherited, like BRCA. BRCA stands for breast cancer, and it's inherited for breast cancer, as it says. And those are called germline mutations. But most are acquired in life, probably as involve the environment, whether that's smoking or ultraviolet light that can cause melanoma, even viruses that get inside the cell, disrupt the cell mechanisms, and can cause errors in cell division. Normally, organisms grow by taking the double-stranded DNA, and let me go back a little bit to high school. In high school biology, double-stranded DNA, and when the cell divides, it splits that double strand into single strands into the two new cells, and then the cell mechanisms inside rebuilds both those two new DNAs so that they can continue to grow. That's how cells normally divide. If there's a problem with that cell division, a mutation can occur, and that's what can lead to cancer. Olga?
Thank you, Dr. Zinner, for that explanation. Dr. Patel, let me bring you into the discussion. Getting diagnosed with cancer is always scary for patients, obviously, but with the advent of new treatments, would you say patients today are in a much better position to battle this disease than those diagnosed years ago?
Yeah, Olga, there's no question. Just listening to Dr. Zinner, it reminds me of when I did my medical training. It's been about 2 decades but it's just been such a dramatic difference from how I was trained and what we could talk about with patients, even on prevention of cancer. And I just want to say, though, I won't minimize, though, Olga, it does not matter how much I can reassure them. Generally, almost to a person, every time, as soon as they hear the word cancer, everything shuts down. So I think some of this is also really making sure that anybody with any diagnosis has that freedom and that space, so that when it shuts down, and we know it will, and their ears shut down, that we also involve kind of a team. And I'm sure my fellow companions on this panel can talk about how they are part of that team. But I think that we are definitely in a better space. I also take pride in how much advancement we've made. You know, we have a vaccine, the human papillomavirus vaccine, that I couldn't offer to people when I was training. So we have vaccines and more technology on the horizon to prevent cancer. And that's stunning. And I think people should stop and appreciate that science made that happen.
And we're going to talk about that vaccine in just a few moments. Thank you, Dr. Patel. Dr. Del Rio, like Dr. Patel just said, cancer is a tough journey for not only the patient, but the family and the caretakers as well. I know that very, very well. What advice can you offer here to those that watch this journey and suffer along the way?
Well, first of all, is that cancer is a difficult diagnosis, but the way to approach it is through multidisciplinary teams. And frequently is not only your physician, but it's actually the entire healthcare team, right? Is the patient navigator, the community outreach person, the social worker, all those different people that help you understand things. I also think that communication is very important. Olga, I'm going to give the experience when my dad was diagnosed with throat cancer. I went with him to the oncologist here in Atlanta at Emory, who I thought did a wonderful explanation of what was going to happen and what therapy he was going to receive and what they were going to do and the different procedures, et cetera. And I thought he did a wonderful job explaining. And then the oncologist asked my dad, do you have any questions? And my dad said no. And then when we got in the car on the way home, my dad said, could you explain to me what just happened? I don't understand anything. And I said, why didn't you ask the doctor? He said, because I was afraid to ask him a question then. So don't be surprised if patients ask questions multiple times. And just because you told them the diagnosis, they may not be, didn't sink in. As Dr. Patel said, everything shuts down. So you as a provider, as a physician, need to give the diagnosis, the explanation over and over to make sure the patient not only understands, but actually sinks in and feels comfortable with the support. But at the end of the day, this is about providing support, not only to the patient, but to the families. Families play a critical role in this, and families need a lot of help because it's an unknown road that many people have never traveled before, and they need the support of everybody, and they need that helping hand in the way.
Thank you, Dr. Del Rio. So later on in the show, we're going to talk about cancer rates for a group that has seen a surprising rise in cases. We're talking about young people. But first, we have an email from Arturo in South Miami, and this is what Arturo writes. He says, I am 75 and was diagnosed with colon cancer a few years ago. I am going through treatment now. I hope there is good news for us seniors battling cancer. So Dr. Zinner, I like what he writes there because he says he hopes, and that word is very important, that there's good news for seniors. What would you say to Arturo?
You know, Arturo, you've actually hit something very important. Age used to be a barrier for treatment. It's no longer a barrier for treatment. But let me turn to Dr. Tice. Dr. Tice, how would you respond to Arturo?
Thank you. So, I think it's really important to know, my colleagues have touched on the multidisciplinary nature of cancer care. And what multidisciplinary means is that we look and we approach cancer care from multiple different areas. We talk about nutrition, talk about family support. We may address the social barriers you might have, transportation support, and those things that are required in order to get you to and from multiple treatments, right? That is no small undertaking. The good news is that much of what has been learned about cancer care has been in the care of older adults because for the most part, that has been the population where those diagnoses have been most common. So we've actually matured our ability to provide holistic care. and address the needs of an elderly population, both by ensuring their social needs are met, as I mentioned, but also in ensuring that things like side effects of treatment that may be intensified with other chronic conditions, other medications you have to take, nutritional needs, et cetera. Really looking to pull all of that together to not just get to the best outcome, but to preserve quality of life along the way. So I do think there are some really tremendous holistic options for seniors who are facing a cancer diagnosis.
Thank you, Dr. Tice. Now, we know cancer strikes in many different regions of the body. Let's take a look at some recent data taken from 2020 from the CDC. We see lung cancer was the leading cause of cancer deaths in America. So here it is. 23% of all cancer deaths were from lung cancer. Another 9% of cancer deaths were from colorectal cancer, 8% from pancreatic cancer, 7% of deaths were caused by breast cancer, prostate cancer, and liver cancer each caused 5%, while other cancers combined for less than 5% as well. Dr. Zinner, it seems like where cancer develops in the body is key in terms of treatment and even survival.
So, Olga, you're dead right. And the reason is if we can detect cancer at some place we can see or feel or has early symptoms, and what do I mean by that? The skin, for example, in melanoma, or breast cancer, which we can see and feel, or even colon cancer, which has early symptoms like rectal bleeding. When we get to treat or diagnose it earlier, we get to treat early. With treatments, we get better survival. Now, the flip side of that is also true. In internal organs like the pancreas, which is basically a silent organ, or even the brain, we often don't see those symptoms until later in the disease. And unfortunately, that's why the survival statistics for those diseases is not as good. So where the cancer is important. Early diagnosis is early treatment, is improved survival. Olga?
Dr. Zinner, can you help us understand what cancer is and how it comes about?
All right, so this one's sort of interesting to me. Everyone in the audience here has a cell phone. And every time we type something into our cell phone, if we misspell a word, there's an autocorrect on your cell phone. Well, it turns out cells in the body also have an autocorrect. And when the DNA splits in two and the cellular mechanisms makes two new DNAs, it can detect when there's an error. And that error is known as a mismatch. And that mismatch can be corrected. That's mismatch repair. And so the body has its own autocorrect. But as we age, that autocorrect function begins to slowly disappear or get less. And so the body no longer has that autocorrect, that mismatch repair. And that causes one of those mutations that we talked about earlier to lead to a cancer. And unfortunately, aging is one of the greatest, if you will, causes or reports as the cause of patients developing cancer. And this is one of the reasons why. Olga?
Thank you for that, Dr. Zinner. I want to turn now to our viewers who are sending in questions. I have one from Sylvia from Delray Beach, and she says, I am a 73-year-old breast cancer survivor. Thank goodness, Sylvia. She also writes, I can attest that advances are being made in the fight against cancer. I was diagnosed several years ago after a mammogram, and I can't thank my doctor enough for catching it early. Thank you so much for that, Sylvia. Dr. Patel, I love this question. I love actually what she told us, because this really reinforces the importance of following suggested screening guidelines. And I know we talk about it a lot, and I know you repeat it a lot in your office as well.
Yeah, so this is a really important point, because I think now, given all the advances in medicine, period, there are so many recommendations, not just for screenings, but we have recommendations on timing of vaccines. We have recommendations on, like, I evaluate patients when they turn 65 on fall risks. And so we do a lot of things. And I think what she's bringing up is to always also advocate for the basics. So we do have times, and she fell into this, recommended breast cancer screening in the form of mammograms. By the way, just so viewers know, there's been a recent guidance that has actually made it, especially for our patients that have kind of dense breasts or have been told that they have dense breasts on mammograms, we've made it easier by having the kind of requirements for how to actually do mammograms, because if anybody's had one, they're not fun. And I think that's another part of it, Olga, is that we try to talk about the timing of these screenings, colonoscopies, or a yearly test that we look for colon cancer. And then also, just in addition to that, a number of, as we talk about vaccines, a number of ways to keep yourself healthy so that we are always in touch with kind of the whole picture of the patient. So I think that I just want to say this, that people who have had cancer, I am now seeing patients who have had, I'm sure everybody on my panel has had the same. I've had patients that have had 3 different primary cancers, and I'm seeing them, and they are very healthy. And that is because we are also doing a very good job, not just in the screening, Olga, but in the follow-up testing and the recommendations from their oncologists or from their doctors about how frequently to follow up on just checking for any, mammograms, MRIs, CT scans, all fancy words, but things that relate to what we're trying to do to stay on top of it. So think of it as screening and prevention. And it doesn't matter, kind of what, for every age, we do have kind of upper limits where we say the risk is not necessarily worth the benefit, Olga, but that's a conversation with your doctor, and incredibly important to have that at least every year.
Thank you so much, Dr. Patel, and you're absolutely right. And that's why we have these town halls, to create that awareness. Dr. Zinner, we've talked about this before as well. Because of COVID, how many people delayed the mammograms, delayed the colonoscopies? And I think it's fair to say there's a price to pay now for that.
That's right, Olga. And now we're beginning to see more advanced disease than we did before COVID. And I'd like to turn to Dr. Del Rio and say, what are the lessons learned here?
Well, Michael, I think, as you and I have said, as I think when you have something like COVID that disrupts the healthcare system and people are told, don't come to clinics, don't come to care, we close clinics, people fall out of care, right? And people, over 2 to 3 years, people did not go to their primary care appointments, did not do their follow-up visits. And now we're catching up. Now we're starting to do all the screening we should have been doing. Now we're starting to take care of chronic disease we should have taken care of. And I think the most important lesson to me, is that we should have not closed clinics and hospitals. We should have done whatever we needed to continue providing care to people, because, the world was transformed by COVID. COVID was not the only thing going on. Other diseases were going on, and we did not pay attention to that, and now we're paying the consequences. So, this is going to be a catch-up period. And my advice to people is try to get an appointment, try to get back in the grove of things, try to get up your appointments that you needed to have. But more importantly, be sure that your loved ones also do that, because, at the end of the day, frequently it helps if I tell my wife, go get your mammogram, or if my wife tells me, go get your screening. It really is a, sometimes we talk about peer pressure. Family pressure is important, and I think we all want to stay as healthy as we can. And this is a good opportunity to do that, is to not just ignore what happened, but actually to try to play catch up.
I agree with you, Dr. Del Rio, and unfortunately, to cliche this for a second, this is like a ticking time bomb with a 10-year fuse, because that's how long it takes to develop cancer if it's been delayed in diagnosis. For example, at our institution, our Cancer Institute, we're beginning to see more advanced first presentations for breast cancer and colon cancer. And Dr. Tice, I'd like to get your thoughts on that, and in all the communities we all treat together. Dr. Tice?
Yes, thank you. This is such an important issue. For all that we learned during our response to the pandemic about health disparities, and certainly it taught us a great deal about the challenges we knew existed as folks tried to navigate the health system that really wasn't designed to allow, to ensure access, rather. As we were navigating our way through that, you and I and others recognized the impact this was likely to have. When you talk about now seeing cancers, diagnosing cancers that are more advanced, you can't have that conversation without acknowledging the fact that disparities existed in cancer diagnoses pre-pandemic. So, for instance, using breast cancer as an example, Black women are not more likely to develop breast cancer, but they are twice as likely to die from it. And if you add to that the pandemic impacts that we've discussed, we should expect even widening disparity gaps in minority populations. The other thing that is really important to note is that there are some cancers that have that are at higher risk in communities of color, and the screening guidelines, for instance, may be different for Black men and prostate cancer. That's another a good example of that. And so again, something that prevents access, delays access, and for which a certain group needs to be screened in a different fashion. It has the potential for widening disparity gaps. And so, one of the things that we must do as we are playing catch up, as Dr. Del Rio mentioned, is be very intentional about oversampling, raising awareness significantly in those communities that we knew pre-pandemic were impacted by health disparities.
Thank you so much, Dr. Tice. Dr. Zinner, I want to talk a little bit about the three most common ways of treating cancer. There's surgery, there's radiation, and chemotherapy, correct?
Correct. So essentially, surgery cuts it out, radiation burns it out, and chemotherapy poisons it. Unfortunately, when you poison the cancer cell, you also impact the other cells around it, but mostly it affects the cancer cell. Now, around 30 years ago, we began doing research in immunotherapy. And Dr. Patel, I want to turn to you. We've gone now from that being an investigative tool to now seeing that in a clinical environment. And I'm curious what you see in your clinic in now the fourth area that we've added to cancer therapies. Dr. Patel?
Yeah, it's timely, and I would say that this kind of spills over immunotherapy. I'm now having conversations around cancer, and by the way, people who have cancer have other diagnoses too. So we've been talking about kind of using immunotherapy on other diseases that also occur and can be treated very effectively in addition to their cancers. So I'll just kind of leave. I think that, Dr. Zinner, it's very fair to say that I feel like we're just still on the precipice of what is an incredible amount of learning about the immune system and its regulation. And it feels like we're constantly, and COVID illustrated that beautifully with monoclonal antibodies and thinking about just how vaccines work. But I think it's in cancer specifically, I hesitate to make predictions, but I hope that kind of by the time I come to like stop practicing medicine, that we will have, for all those categories you just mentioned, we will have in each one of them something that can effectively treat. I think, that is something that I feel like is within our reality. I never could have said that 2 decades ago. And I will say what's also humbling is watching not just the development of those immunotherapies and kind of working with patients, where I come in when Dr. Tice kind of is like the oncologist on the team. Usually where I come in is helping manage the other chronic conditions, and then also doing some of the work with the entire team around managing side effects or making decisions about, when do I need to go to which part of my team. And immunotherapies have helped to kind of expand what we can do to talk with patients about what is available for treatment, but also for education around some of these signs and symptoms and side effects. And so it's pretty stunning to see what's developed.
Thank you, Dr. Patel. Dr. Tice, I want to go back to you because I just got a question from Denise, and she writes, I'm a 28-year-old Black woman with a family history of breast cancer. Should I get screened? Your thoughts and your response to her, please? I think Dr. Tice is having an issue with her Wi-Fi. So let me go to Dr. Patel. Let me give that one to you if you don't mind.
I was just going to say, I'm not the best person to, so I would first also talk with Denise about her family history, because again, depending on what her family history is, looking at specifically which family members and which side of the family, that can also play a factor in recommending. But what I would do is, after doing that, if I have any questions, because this is earlier than we would recommend for women to get screened. But again, depending on types of cancers in the family, which members of the family, that could absolutely accelerate the screening. So unfortunately, the practical answer for her is have this conversation with your doctor. And I'll put a plug in for the fact that you can do this virtually, just because there still are incredible resources on a telehealth basis where I can do that kind of counseling with a patient and do it quickly, because I'm sure it's something that she's worried about.
Thank you so much. Dr. Zinner, I'm going to also give it to you and see if you have any thoughts for her.
I would I would recommend the discussion with her physician. Absolutely correctly, Dr. Patel is correct. Need to know the family history, but as was brought up by Dr. Tice, there are two things that this young woman needs to think about. One of them is there is a higher mortality rate in that population, but two, we're beginning to see younger and younger women who we didn't ever think would develop breast cancer, but developing breast cancer below the age of 30. So if there's a suspicious lesion, if there's a family history, or if there are other indications that a mass is felt, then I would absolutely get her screened. It'd be very, very important.
All right. And Dr. Zinner, I have one more question, and it's from Judith. It has to do with pancreatic cancer. And since you were a pancreatic surgeon, I'm going to give you this one. She writes, and I'm going to paraphrase a little bit, what screening, if any, is available for detection of pancreatic cancer? I didn't have any of the symptoms of pancreatic cancer. My doctors found it by chance. Your response?
I wish I could give better hope in this area, but unfortunately, unlike many of the cancers we deal with, there is no good screening test for pancreatic cancer. There is one objective criteria, though. If you have, later in life, developed type 2 diabetes and don't have a family history, sometimes that's worth screening. There are some tests that you can do, like a CAT scan or an MRI, but that's only if you have a suspicion of a lesion there or a family history, as we just talked about in the previous discussion. But unfortunately, unlike breast and colon and lung, we don't have adequate pancreatic cancer screening tests.
Thank you, Dr. Zinner. A couple minutes ago, we just discussed the multiple, more traditional ways of treating cancer. But thanks to modern technology, there are some medical advances that are state-of-the-art. One such method is called proton therapy, and it's used to treat a variety of cancers. Take a look at this.
What is proton therapy? Proton therapy is a non-invasive procedure that may offer fewer side effects than those associated with conventional radiotherapy. With conventional radiotherapy, the dose doesn't stop at the tumor. Proton therapy uses a beam of protons to deliver cancer-fighting radiation directly to the tumor, while minimizing damage to surrounding healthy organs and tissue. The ProBeam 360 system uses high-definition pencil beam scanning to deliver intensity-modulated proton therapy, which is recognized for its precision and effectiveness. It's considered an advancement over other proton therapy delivery methods. There are 3 steps to proton therapy treatment. They consist of CT simulation, treatment planning, and treatment delivery. During CT simulation, your treatment team will take images to reveal the exact location of the tumor, including its size and position relative to the surrounding tissues and organs. Imaging is typically done with a CT scan. Additional types of scans may be taken, such as an MRI or PET scan. Depending on your treatment needs, a custom body mold or mask may be made, and tiny skin marks may be used to help ensure you're in exactly the same position for each treatment session. The CT images will be used to design your treatment plan. During each treatment session, your radiation therapist will help position you on the treatment table, also called a couch. You'll be positioned on the table in the same way and with the same immobilization equipment that was used during your CT simulation. Your radiation therapy team will use the machine's imaging system to take a new image of the tumor in that day's treatment position, and may adjust your position for accuracy. During treatment, the proton delivery mechanism, or gantry, moves around you. You'll hear the gantry moving, and part of it may be positioned close to you, but it will not touch you. Your radiation therapy team will be monitoring your treatment at all times. Before starting your treatment, the team will move to the treatment control room and will be in constant contact with you through the cameras and microphones in the treatment room. The ProBeam 360 system's pencil beam scanning delivers the proton beam layer by layer, spot by spot, like a 3D printer. This helps deliver accurate treatment while minimizing radiation exposure to surrounding healthy tissue.
Dr. Zinner, that was truly amazing information. Talk a little bit, if you don't mind, about the advantage of using a targeted treatment like proton therapy. A lot of people haven't seen this.
So what you just saw is literally targeted therapy. And by that, we mean we're directing the therapy only at the cancerous tumor and not the surrounding tissue. And that's what you just saw is the state of the art for radiation therapy. But we're developing a whole new class of chemotherapy agents that are just like that, but chemotherapy. They're called antibody drug conjugates. And what they are is they attack only the cancer cell and they leave the rest of the cells alone. And when we used to talk about, or when we still talk about chemotherapy, it's a little bit like carpet bombing. I mean, everything gets blasted, the good cells, the bad cells, and everything in between. But what we're going to is more of this targeted therapy, which is more like a laser-guided missile, just targeting the cancer cell. That's the future of cancer therapy, both in radiation as well as in chemotherapy. Olga?
What an advancement. Dr. Del Rio, can you talk about just the value of clinical research and clinical trials as we search for better treatments for cancer? I mean, they're really important, aren't they?
There's no doubt about that. The way we advance at therapies, the way we advance diagnosis, is we do it through clinical trials. And ideally, there's comprehensive. There's NCI supported cancer centers, and they're comprehensive cancer centers. And there's networks that do clinical trials in cancer across the United States, across the world. And the reality is that cancer therapy advances because we have this comprehensive clinical trials network that do the kind of research that is necessary to take a drug from a discovery at the bench all the way to a drug that can be delivered to patients that can change therapy. And I think, for example, about how, the story of the PD-1 inhibitors is just a wonderful story of a drug that was developed because people were working on viral interference, and they were looking at how viruses and cells prevent viruses from coming in. And then they discovered that this molecule, PD-1, also had impact in how cells responded to cancer cells. And this led to the development of drugs that then went to clinical trials and proved to be effective in the management of multiple tumors, including, for example, melanoma. And we're seeing a dramatic change in the management of many tumors as a result of the development of this molecule called PD-1. So there's plenty of examples of how a discovery in the laboratory is taken all the way to the clinic to benefit patients, but it has to happen through this long and expensive process called clinical research, and really the support of the federal government in having wide-ranging cancer clinical trials networks is really critically important. And cancer centers do a wonderful job enrolling patients. And when patients with cancer come in, Dr. Zinner was talking, for example, about pancreatic cancer. We need to find better therapies for pancreatic cancer. So patients with cancer frequently will go to a clinical, go to a center that does clinical trials for their care, and they will frequently be said, well, do you want to participate in a study? And the reason they're participating is because that gives them access to novel therapies, but it also, that's how they contribute to advancing care for the disease. So clinical trials are a must, and in cancer, they really change the paradigm and they advance. That's how we make advances.
And Dr. Tice, I want to bring you in because I think this is such an important topic, these clinical trials, especially in some communities where they're not really very receptive to be part of them. Participation is not very popular, let's just say. And I'm going to be completely honest. My brother, we were offered a clinical trial for my brother at Miami Cancer Institute, and we hesitated, and we weren't going to partake, and we decided to move forward. But there's a lot of Hispanics out there that say, no, I don't think so, and even African Americans. How can we improve this?
So, I think the mistrust is not unfounded with the health system, and I think we have a responsibility to address that directly. We have to acknowledge the sources of that, and we have to work to establish strong relationships with communities of color on the other side of historic maltreatment. The other thing that I think we need to do is recognize the value of incorporating and including minority physicians in some of these solutions, right? The underrepresentation across the healthcare system of minority physicians, it actually contributes to this. Is more people of color are likely to be cared for by a physician that is aligned racially or ethnically. And it is that physician or clinician with whom they establish trust and build that excellent rapport in the guidance of their healthcare. But there is a lack of recruitment in many cases for minority physicians to participate in clinical trials, and as a result, trials don't have access to their patients. And so there are a number of initiatives underway to try to improve that. And minority medical associations across the country, and including here in Florida, are actually stepping out to do specific things to improve the representation for minority physicians and clinicians in the clinical trial arena. I think both of those things need to happen. And I think we need to acknowledge that the thought leadership and the trust may not necessarily exist with majority medical institutions for communities of color.
Thank you, Dr. Tice. And Dr. Patel, I'd like you to chime in as well, because a lot of people, like Dr. Tice was talking about now, and again, I'm going to include myself. You know, we felt it was an experimental therapy, if you will. But we had the awareness, the education from our physician, which really helped. Can you explain to our viewers how these trials are conducted?
Yeah, so there's an incredible amount of kind of, I'll call it regulations, oversight, but they're really protections to make sure that there has been a history in our country and around the world of abuses of clinical trial participants, and frankly, just this disgusting history of racism that we have had. And I think as a result, constantly we are trying in clinical trials that I've participated in helping to recruit patients in, there's always not only a rigorous protocol that we follow, but also an incredible amount of resources so that we can have people ask questions and have counseling. The most common question I get, Olga, when I'm talking with people about trials is they're worried that this is not, that they can't get regular health care, this is different. So I just want to kind of stress and emphasize that there is no denial of any medical care, and think of being in a clinical trial and understanding what you're doing, the informed consent, as we call it. You really do have to consent. You agree to be a part of it. And that first word, informed, is something that we are bound to, not only as people who are working in clinical trials, but I myself, as someone who's encouraged patients to be in these trials, am bound to follow through with informing patients. So it's not just one and done, you go into a trial. The oversight, touching base with patients, it's often more frequent blood draws and getting different types of imaging that can be part of the process. And so it's also saying to someone, look, I want to raise my hand and participate, but I have a full-time job and I'm worried about that. How can I get some flexibility, or what would I need to do? And that's something that we can talk to people up front about. And then I do want to say something, because some people feel like they're being experimented on. And Olga, if let's say they are part of a trial, and I have had patients ask me, what if I'm in the trial and there's a drug that works and they won't give it to me because I'm a woman of color or I'm poor? And something that we try to do is also stress the randomization, that there is actually a process by which not only are we making sure that we treat people who get potentially a treatment and maybe don't get the treatment, that we make sure that those are equal populations. But if we see data that is incredibly compelling, that a person in that treatment group is doing well, that's where the Food and Drug Administration, along with the agencies kind of overseeing the clinical trials, Olga, they can even stop and say, this is so important and such an important development. We need everyone to have access to that therapy. So reassurance that they're not going to be denied something or minimized because they do participate in a trial.
Thank you so much, Dr. Patel. Great information. I want to take a look now at more specific cancers. One of the deadliest and more common cancers today is colorectal cancer. Let's take a look at this video.
Living Minute, a look at the latest medical innovations changing our lives.
Colorectal cancer is one of the deadliest cancers in America.
It's the third leading cause of cancer death in the United States. It affects men and women equally, And we expect in a year about 50,000 people will die from colorectal cancer.
It happens when the cells in your colon or rectum grow out of control. Recent studies have shown that more people are developing the disease at an earlier age.
10% of colorectal cancer cases now are going to occur in people who are under the age of 50.
Those at most risk are African Americans with a family history of colorectal cancer. Also, certain health conditions like inflammatory bowel disease can increase the risk. The best way to prevent it is to get regular screening starting at age 45.
Yeah, that's great information. Dr. Patel, sadly, colorectal cancer is another one of those diseases affecting lots of people across the board, and as we heard, of all ages now. Can you talk about the role of diet and lifestyle and how that might affect cancer occurrences?
Yeah, so this is something that I hope kind of everybody hears, even if they've recovered and been able to go through cancer therapy. Diet and lifestyle are just as important as some of the prescriptions we write. And I think this gets back to really utilizing your team, having somebody who understands. For example, if you are part of a racial or ethnic group where there's a certain type of diet, I'm Indian, if I had somebody give me a very generic diet that didn't actually acknowledge some of how I can eat healthy using foods that I more traditionally would prepare, then Dr. Zinner, it's just going to fall on deaf ears. So I think there's also having all of the components of what is realistic for you to do in your lifestyle and create an individualized plan for that person, because we are all individuals. We're very unique. You can't use a template on every patient. But I also kind of stress that, again, going through these therapies, whether it's, as you mentioned, the surgery and a chemotherapy or any one of those buckets to help treat colorectal or any of the other cancers, that we have to support kind of diet and lifestyle and even exercise during the process. Some people have kind of said, you know what, I can't do anything. And they have like a misunderstood, they don't understand how they can keep active, how there is also a mental health component to this. We now have enough research to show that if you do have a mood disorder or depression, that affects kind of your course of treatment and also your recovery. So we, as I learned in medical school, like the body, you know, medical disease doesn't stop at the neck. It is the whole body, and that includes lifestyle and diet.
Thank you, Dr. Patel. Dr. Del Rio, I just want to recap for our viewers screenings for colorectal cancer. The age, they were recently lowered. Is that correct, Dr. Del Rio?
Correct. There has been recent changes in the screening for colorectal cancer. And it is recommended, you know, it is recommended that different things be done. I mean, you can do screening for, screening really starts nowadays at age 45. And this can be done in different ways. It can be done by screening for the presence of what we call occult blood. It can be done through colonoscopy. It can be done through different ways. Now there's what we call non-invasive colonoscopies. But yeah, it is recommended now, you know, it used to be age 50, now it's recommended at age 45, because we are seeing an increase in people with colon cancer that are, you know, 1 in 5 people with colon cancer are between the ages of 45 and 49. I want to add one thing also about, you know, what Dr. Patel said about the importance of healthy living. You know, people frequently don't recognize this, but obesity is a risk factor for multiple cancers. And again, something as simple as increasing your weight, people know it has impact on diabetes, cardiovascular disease, but also increases your risk of cancer. So yes, another reason to lose weight is to decrease your risk of cancer. So there's many reasons why having a healthy weight is good for your health, and cancer prevention is one of them.
Thank you, Dr. Del Rio. Earlier, actually, at the top of our show, Dr. Patel talked about HPV vaccine, and we want to talk about HPV and its effect on the body. In fact, Dr. Alessandro Villa, the chief of oral medicine, oral oncology, and dentistry at the Miami Cancer Institute, he joined us earlier, and we asked him how HPV can actually cause cancer. Take a listen.
Human papilloma virus is one of the most common sexually transmitted infections in our country. and it's known to cause the majority of throat cancers in the United States. More than 70% of throat cancers, it's what we call oropharyngeal cancers, are caused by a virus, the human papilloma virus. But HPV can also cause other cancers like cervical cancer, some of the anal cancer, penile and vaginal cancer. And over the past few years, we saw an increase in the number of throat cancers that are HPV related. HPV, it's a skin-to-skin infection, and we are seeing an increased number of oral HPV infection, which ultimately leads to an increased number of throat cancers. These may be caused by a difference in sexual habits compared to several years ago, but what we're seeing is an increase of HPV-related oral infections that ultimately, again, leads to HPV-related throat cancers. The HPV vaccine is one of the 2 cancer prevention vaccines that we have available. It's safe, and it's usually recommended between the age of 9 and 26 years. We are seeing that the vaccine can prevent many diseases, including cancers. I think that the story with HPV, which prevents a cancer that is related to a viral infection, it's an excellent story, and there are several clinical trials now testing vaccine for other different types of cancers. So this is definitely an exciting time, and hopefully we'll see more and more vaccine in the future that can prevent also other cancers.
You know, Dr. Zinner, it's hard to believe that this or any virus can actually lead to cancer.
You know, Olga, you're right. It's so interesting to me that how things have changed over my career. I want to turn to Dr. Theis. So here we are talking about a vaccine that can prevent cancers, but he's talking about a younger age group for us to give this vaccine. Why is that? And can that be expanded to other populations and other age groups?
Well, you know, that's actually a really good question. And I think the important thing to point out is you're talking about a vaccine that protects against a viral infection. And the trouble with human papillomavirus is that most people have been exposed or infected by this virus by the age of 26. So the age range for completing the 3-part series for the HPV vaccine is 15 to 26, because that's when you are likeliest to benefit from the protection that vaccine confers against contracting HPV virus. It can be given as early as age 9. But after age 26, it really is not much value, as most people have sort of seen the virus by then, and the risk reduction doesn't exist.
Thank you, Dr. Theis. I have a question from a viewer. And Dr. Patel, I'm going to ask you to give me your thoughts, please. It's from Muriel, and it's on Facebook. And thank you, Muriel. She writes, do you need evidence of a disease to qualify for trials? I finished radiation treatments on April 10th and have to wait for at least 2 months for a scan. Can I be in a trial before I find out the results of the scan to see if I have any remaining disease? Great question there. Thank you so much, Muriel.
It's a great question, and it depends. So I know that's not a satisfactory answer, Muriel, but it depends on what the trial is for. So there could be a situation where, and again, it goes back to having those strict protocols in place, which are actually meant to protect anyone that participates in a trial. And so it is, depending on the details of the trial, you may be able to participate. But don't be shocked if they want to have all the information about your health, including the results of a follow-up scan, if it's indeed just several months away. They may say, listen, we'd rather have those scan results, or we'd rather wait until X months out. And it's worth asking, when will you look at enrollment for patients again? Because many times in trials, we'll have a period where we enroll patients, and then we kind of close that enrollment, and then we might have additional enrollment times. So, but I applaud the enthusiasm and ask the question, because there could be an answer that you could do it today.
Thank you, Dr. Patel. So hearing about advances in cancer can make us very hopeful, but we mentioned earlier a trend that is really concerning, and that is the rise of cancer in adolescents and young adults. Take a look at this. In a report from the National Cancer Institute, an estimated 87,000 adolescents and young adults between the ages of 15 to 39 were expected to be diagnosed with cancer in the United States last year. This accounts for about 5% of all cancer diagnoses. Dr. Zinner, I wanted to get your thoughts on these numbers, which not only are alarming, but just shocking.
Well, it's very shocking to see the kind of numbers we're seeing there, but unfortunately, we're beginning to see that, and we're seeing that in our own patient population. I would say that we've got to be more vigilant. We've certainly got to pay more attention to symptoms that we might have disregarded in a younger population now become much, much more important. So, Olga, let me turn this back to you.
Thank you, Dr. Zinner. Dr. Del Rio, we all know the sad story of Chadwick Boseman, the star of the Black Panther series. He was diagnosed at 39 years old with colon cancer and passed 4 years later. Now, with all the advances, it seems we have taken a step back in some ways. Why do we think cancer is impacting more people at a younger age?
Well, as Dr. Zinner said, we don't have all the evidence. It could be lifestyle. It could be, exposures in the environment. It could be different things that are causing that. But the reality is that we are seeing that, and a cancer diagnosis, while we have made advances, continues to be, a difficult road ahead. And people, lung cancer, breast cancer, colon cancer continue to be major causes of death in our population. So we have to do what we can to diagnose early and to start treatment early. The earlier you diagnose, the earlier you start therapy, the more likely you are to be successful when you're managing cancer. So at the end of the day, it's about paying attention to your body, about paying attention to symptoms. You notice some blood in your stool, you notice something it doesn't make any sense, go check it out. Go check with your doctor. Don't ignore symptoms, because frequently ignoring a symptom could be deadly. So again, you need to really access care. But we have the issue. We have the problem that, number one, people ignore symptoms, but number two, we have difficulties accessing care in our country. I mean, many populations simply don't have access to primary care, don't have access to screening. So we have to do a better job at providing primary care to patients in order for them to be, diagnosed early and to be screened and to be access to prevention interventions. We talked about the HPV vaccine. What a wonderful intervention, right? We could end not only oral cancer, we can end cervical cancer that still kills about 5,000 women every year in our country and more than 500,000 women globally. Cervical cancer could be a disease that we can eradicate if we use this vaccine effectively. And I can go on and on, but multiple things we can do to prevent cancer, stopping smoking, etc. So, cancer prevention is critically important. It is primary care physicians, it's people working in the community that do that. So we have to have access to community cancer screening programs in our communities, and we have to do it primarily in minority communities and people that have an excess burden of disease.
Thank you so much, Dr. Del Rio. So as we wrap up this amazing hour filled with so much information, I'd like to get final thoughts on the battle against cancer from all of you, of course. Let's start with you, Dr. Patel.
Yeah, I have one message, science works, and then a second message. If you are encountering those barriers that Dr. Del Rio just articulated, try to think through how we can help overcome those barriers. I'll give you one example, Olga. Most of the country, over the age of 40, you don't need a referral or a doctor's order to get a screening mammogram. You can go and get that in the majority of the country without an appointment with a doctor if you just need a screening mammogram. So there is always a way. Advocate for yourself.
Thank you so much, Dr. Patel. Dr. Tice, let me turn it to you. I have about 30 seconds.
Thank you. This has been a wonderful discussion. I think the thing I'd like to leave you with, I'm GuideWell's first ever Chief Health Equity Officer, and I'm a family physician. And we've talked a lot about disparity gaps, and the one missing piece, I think, is true patient empowerment. So building systems of care that allow people to know and own their own health, and walk with an understanding of what it takes to be healthy, access to the behaviors, healthy behaviors that keep them healthy, and access to the appropriate care and treatment.
Fantastic information. Thank you so much. Dr. Del Rio, again, I've got about 30 seconds for you as well. Thank you, sir.
Very, very simple. My message would be two things. Number one, cancer centers need to work closely with their communities that they live in, and they need to reach out to the communities, not wait for patients to come to them. And the opposite, if you have resources, any resources, you don't need to be a millionaire. donate, contribute to your cancer center, because your cancer center, with those monies, can do programs, not only research, but can reach the communities, can create community programs, and that's something we desperately need.
Thank you so much, Dr. Del Rio. And Dr. Zinner, I've got about 30 seconds for you as well.
I spent my entire career in cancer, and I will tell you, we've come a long way, but we've got a long way to go.
Thank you so much, Dr. Zinner. And I want to thank all of you. A terrific panel. Thank you for your time, your knowledge, your information. It's always such a pleasure to have you all. Dr. Zinner, as always, thank you for being my co-host. And to all of you, thank you for joining this special town hall. Hope and healing, finding answers to cancer. I think everyone in this panel would agree that you never lose hope. Even when you hear a diagnosis like cancer, you pray, you have faith, and you never lose hope. I'm Olga Villaverde. We'll see you next time, and as always, you take care.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.